Welcome to The Explainer. Today, we're diving deep into thyrotoxicosis. We're going to build a high-yield clinical guide from the ground up, something perfect for you if you're a busy med trainee on the wards or cramming for your next exam.
We're going to approach this just like a real clinical case. We'll start with the absolute basics, then we'll walk through the workup and diagnosis, lay out the management plan, and wrap up with the one emergency you absolutely have to know cold: thyroid storm.
Okay, let's kick things off with a really foundational concept. Nailing this next definition is so important, not just for your exams, but for your day-to-day clinical reasoning.
So let's get this straight, because it's a common point of confusion. Thyrotoxicosis is just the clinical state of having too much thyroid hormone in your system, and it doesn't matter where it came from. Hyperthyroidism, on the other hand, is the specific process of the thyroid gland itself going into overdrive and pumping out too much hormone. So here's the bottom line. All hyperthyroidism causes thyrotoxicosis, but not all thyrotoxicosis is caused by hyperthyroidism. And you'll see why that's such a big deal in a minute.
Okay, picture this. A patient walks into your clinic with that classic triad. Their heart is racing, they're losing weight without trying, and they feel hot all the time. You're thinking thyrotoxicosis for sure. So, what do? What's the most logical way to work this up?
Your workup always starts with one test, the TSH. See, the body has this beautiful negative feedback loop. When there's a ton of thyroid hormone floating around, the brain gets the signal to shut down TSH production. So a low TSH is your first major clue. From there, you confirm it with a high free T4 or T3, and then the real detective work begins to figure out what's causing it. And that right there is the million-dollar question. The answer to this is going to dictate your entire management plan. Is the thyroid gland itself just working way too hard? Or is something else going on? Luckily for us, there's one key test that really helps us sort this out.
So, to unmask the cause, we're going to split all the possibilities into two big buckets. And we do that based on a single test, the radioactive iodine uptake scan. This right here becomes the central branch point for our entire diagnostic algorithm.
So the radioactive iodine uptake scan, or RAIU, is basically a test of how hungry the thyroid gland is for iodine. If the gland is sucking up a lot of it, that's a high uptake. It tells you the thyroid factory is working overtime. That's true hyperthyroidism. But if the uptake is low, it suggests the hormone is just kind of leaking out of a damaged gland, like we see in thyroiditis, or maybe even coming from pills.
And this table just lays it out so perfectly. You can see in the high uptake camp you've got Graves' disease, with its classic stimulating antibodies and toxic multinodular goiter. Then, in the low uptake camp, the classic example is destructive thyroiditis, where the gland is inflamed and just dumping out pre-made hormone. See how the RAIU is the test that really splits the differential wide open?
All right, so you've cracked the case, you have your diagnosis. Now it's time to build our management plan. And it's really a two-pronged attack. First, you got to control the symptoms to make the patient feel better fast. And second, you have to treat the underlying cause.
For almost any patient who feels lousy from this, your first move is a beta blocker. Think of this as your rapid response tool. It doesn't fix the thyroid itself, but man, it works wonders for the racing heart, the shakes, and the anxiety. It provides that immediate relief and buys you the time you need to get the definitive therapy started. Now, for the long-term fix for an overactive thyroid, you've got three main tools in your toolbox. You can use antithyroid drugs called thionamides, like methimazole or PTU. You can use radioactive iodine to kind of quiet down the overactive cells, or you can go for surgery and remove the gland. Which one you choose really depends on the exact diagnosis, the patient's other medical problems, and, of course, a conversation with the patient. Now, if you do start a patient on a thionamide, there's a crucial piece of counseling you have to do. You have to tell them about these rare but really serious side effects. The instructions are simple and non-negotiable. If you get a fever, a sore throat, or if your skin or eyes turn yellow, you stop the medicine immediately and get help. This is a huge patient safety point.
And finally, let's talk about the highest stakes scenario in all of thyroid disease. This is the one you hope you never see, but you have to be ready for. This is thyroid storm, where thyrotoxicosis goes from a serious problem to a life-threatening multi-system meltdown.
Yeah, just let that number sink in. A mortality rate that can be as high as 30%. This tells you that thyroid storm isn't just really bad thyrotoxicosis, it's a state of complete systemic decompensation that requires immediate, aggressive ICU-level care.
And here's the really critical part.
The diagnosis is purely clinical. There's no lab test that's going to flash thyroid storm. You have to recognize the pattern at the bedside. A patient with thyrotoxicosis who suddenly develops a raging fever, a heart rate that's way out of proportion, confusion or even a coma, and signs that their organs are failing. And it's almost always kicked off by some other stressor, like a bad infection or surgery.
Okay, so management is a full-court press. You have to hit this from multiple angles all at once. First, you block the hormone's effects on the body with IV beta blockers. Second, you block the factory from making any new hormone with a thionamide. Third, and this timing is absolutely critical, at least an hour after that, you block the release of all the pre-made hormone with potassium iodide. And finally, you give steroids to block the conversion of T4 into the more powerful T3. It's a complex dance for a complex crisis.
So we've gone all the way from a basic definition to a full-blown critical care emergency. You know, building a strong mental model for thyrotoxicosis. It's not just about passing a test. It's about being ready when this rare but incredibly deadly condition walks through your door and every single minute counts.